Yeah, so I recognize some names just maybe through our addiction consult service. Um, I guess by way of introduction, then did my psychiatry residency over across the park at Mount Sinai on the east side. I was here last year for the addiction psychiatry fellowship, and now stayed on. I'm attending on the inpatient detox unit, and I work on the addiction consult service as well. So I can go into a little bit more information, maybe even towards the end, about what exactly the addiction services are at the hospital, just so you guys know, how to get in touch with us, all that stuff. But for now, I guess we'll jump into the talk. Your chiefs asked me to make this case-based series and try to keep it interactive. So I encourage participation as much as possible. When you guys have questions, if you have thoughts on what's going on, just feel free to jump in. I thought about making this talk on alcohol and opioids because I think those are the most common addictions you guys run into in terms of management on the floors. But I had a hard time squeezing everything in. So I wanted to focus more on alcohol today because I think it's probably the most prevalent thing, and also the more dangerous of the two. Would be happy to come back and actually do a subsequent talk at some other point on opioid addiction and withdrawal if that'd be helpful. So with that, we will dive into a quick note on epidemiology because every talk has to start with some epidemiology. So the importance of this issue, I think, is noted just by the prevalence. So the prevalence of alcohol use disorder in the community is estimated to be around 14%, which is quite high. The prevalence among hospitalized patients is actually much higher. Nearly 50% of people hospitalized would meet criteria for an alcohol use disorder. That may be a milder use disorder, right? Which is why we don't always come up against it or realize we have to treat this clinically. But of those 40%, approximately half with AED do experience some form of alcohol withdrawal when they stop drinking. So that's a pretty large percentage of hospitalized patients. The symptoms we're talking about here that would sort of account for such a percentage, I think, can be relatively mild, from just tachycardia to maybe a little bit of tremulousness. So sometimes it's lost among everything else going on. But I think it's important to just kind of recognize how prevalent this is. All right, so with that as by way of brief introduction, we'll dive into a little bit of a case here. So we'll start here with a 45-year-old woman, no known medical history. She comes to the ED, brought in by EMS after new onset seizure. As you're going down to see her in the ED, she starts to seize again. What do you guys do? What are the first steps here?
Stop the seizure.
Stop the seizure. Good first step. What's an approach you would take for that?
IV lorazepam, probably.
Yeah, benzos, right? That's kind of what we turned to initially. If somebody's just coming to the ED, they may not yet have an IV, right? In which case we can use IM medications too. We can use IM benzos. You mentioned lorazepam. Do you guys have experience with any other benzos?
Midazolam as well.
Midazolam as well. Yeah. Yeah. There are, of course, a number of different ones that we can talk about and think about using. Obviously, when we're talking about alcohol withdrawal, the treatment of choice, as we'll sort of keep harping on in this lecture, is benzos. This is the one time you're going to hear any psychiatrist recommending benzos. But there are a number of different ones. These four, I think, I listed as kind of the main four we see used around the hospital. And this is kind of how I think of them. So, I think we're most familiar with using Ativan, right? That was the first one you guys mentioned up. I think we We use it frequently because it has an IAM form, it's got an IV form, it's got a PO form. And that's what we're most familiar with. So of the four of these guys, Ativan IM probably has the most rapid sort of onset of effect, which is an important thing to know if you're dealing with an acute withdrawal syndrome like alcohol or like a withdrawal seizure, right? Because we can turn right to Ativan IM, whether or not they have an IV access, and treat what's going on in front of us, and we'll know that it'll work quickly. This is one of the ones we turn to as well when there's impairment in hepatic function. Do you guys recall the other two that we use commonly when people have liver injury?
Oxazepam and temazepam.
Nice. Okay. Somebody remembers the lot mnemonic, right? So lorazepam, oxazepam, temazepam are the three benzos that are more primarily cleared through the renal system and the liver. The other three here that we talked about, so Valium is another one that's commonly used for both the treatment of alcohol withdrawal or for the acute treatment of seizures. So it actually has the fastest onset when we're talking about the IV form or the PO form. So if you want sort of a generic, quick effect, quick onset for a PO medication, Valium is the best one to turn to. It's actually much slower than Ativan in IM form. So if somebody doesn't have IV access, we'll want to go back to using Ativan. But if we're talking IV or PO, it tends to be the one we turn to most commonly. It's nice too when we're thinking about a withdrawal syndrome because it does have active metabolites. It has a longer half-life, as you can see here. So it sort of builds up in the serum with multiple doses. Are you guys familiar with Librium at all? Do you use that on the floors?
I've seen it a lot for alcohol withdrawal on the floors and in the ICU.
Yeah. So I think Librium is one of the first benzos that came out. They got the sought after FDA approval for the treatment of alcohol withdrawal. So just sort of on a historic basis, I think it's the most commonly used for alcohol withdrawal. It doesn't have any IM or IV form, which is why we don't use it in the acute setting as much. But if we're talking about a benzo taper or sort of a standing regimen for alcohol withdrawal, typically we turn to Librium just based off of sort of historical comfort with the medication. And then you mentioned Versed earlier as well. That is actually, of all the benzos, this is one of the fastest onset. The thing you got to remember with Versed though is really short half-life. So if you're treating something like a withdrawal syndrome, which is going to have a more prolonged lifespan in the patient, you run the risk of recurrence of symptoms pretty quickly. So we'll get a little bit more into the sort of specific regimens and how we think about using benzos, but that's kind of a brief overview. You guys have questions about those? Okay. All right, so she gets 2 milligrams of IM Ativan, seizure stops, and we accomplished our goal there. After a brief postictal period, she tells you she's got no history of seizures, but she's recently been trying to stop drinking. So, does anybody know why she was seizing? What was going on in her brain? Do you guys recall learning anything about the Gaba receptors in the brain? Right, this is the neurotransmitter that we think about with alcohol use and which benzos activate as well. Right, so it's the primary inhibitory neurotransmitter in the brain. It's a ligand-gated ion channel. When activated, you get the influx of chloride ions, which results in hyperpolarization of the neurons. And this is what causes the inhibitory effect, right? Alcohol, benzos, they both activate GABA receptors. And this sedatory inhibitory effect on the brain is what causes the sensations of alcohol intoxication, the thing you got to remember with the brain as well as the rest of the body, right, is that with chronic long-standing use of any substance, your body's going to want to work back towards some state of equilibrium, right? A state of reestablishing homeostasis. So what it does when you're abusing alcohol on a chronic basis, right? Your brain is constantly flooded with alcohol. It's constantly having the GABA effects and the GABA receptors activated. In order to balance that out, what it does is reduces the sensitivity of the receptors to alcohol, as well as to other ligands, including benzos. So it's sort of balancing out the effect of all the alcohol by reducing the endogenous tone of the GABA receptors. On the flip side of the equation, we have glutamate, right? Glutamate is the primary excitatory neurotransmitter of the brain. So GABA hits the brakes, glutamate is the accelerator. At the same time that alcohol causes an increase in the GABA tone, it blocks the glutamate receptors and causes a decrease in the glutamate tone. So we're both increasing the inhibitory tone and decreasing the excitatory tone. Your brain will do the same thing over time with long-standing alcohol use. In order to balance things out again, it's going to increase the number of glutamate receptors in the brain to try and maintain that homeostasis and maintain some degree of arousal in the face of all the alcohol tone. What that means, right, is that after you've maintained this, or you develop this sort of new state of homeostasis that's trying to keep your brain sort of persisting in arousal in the face of all the alcohol, if you remove the alcohol from the equation, you're left with a brain that has no brakes and only the accelerator, right? Because you have that decreased GABA tone that's endogenous now and the increased glutamate tone. And your brain's basically going sort of at 100 miles an hour without the ability to stop it, right? There's no sensitivity to GABA anymore. So you can kind of see this in this illustration, right? The acute effects of alcohol intoxication, you get an increase in the GABA tone, right? An increase in the inhibition of the brain and decrease in the glutamate tone. That causes the sedatory effects of alcohol. Over time, right, you get reduced GABA sensitivity, increased glutamate sensitivity, which balances things out. But as soon as you take the alcohol out of the equation, you're left imbalanced again in the opposite direction. And this is what alcohol withdrawal is, right? This is what causes seizures, what causes tremors. Your brain is sort of ramped up at an unregulatable pace. So that's what's going on inside the brain. This is also, right, why we use benzos to treat it, because in giving benzos, we're reinforcing the inhibitory tone of GABA, which helps to balance things out again when somebody's in withdrawal state. Does that make sense to you guys? Any questions? Okay, so getting a little bit more into the case here then. You get a little bit more history. You hear that recently she's been drinking around 1/5 of vodka per day. Does anybody know how much vodka that is? People throw around lots of terms for amounts of alcohol use. Anybody
Is it
familiar?
200 cc's?
200? You
I
would
would
think, right? It's called 1/5. I don't know what it is 1/5 of, but these are the. One sec. I'm gonna. Okay, sorry about that. These are the amounts of alcohol in sort of their common terms. And so 1/5 is actually the sort of the typical 750 milliliter bottle of alcohol. It's a lot to be drinking a day. It's equivalent to 16 shots. You'll also hear people talk about drinking a pint of alcohol a day. Some people do a liter. You'll hear people talk about a handle of alcohol a day. So these are, as you can see, relatively large amounts of alcohol to be consuming on a daily basis. All right, so we get into more of the history here. Her drinking worsened over the course of COVID, prior to which she'd been doing a few drinks of wine a night that progressed to a bottle per day before eventually she switched over to vodka, and it just escalated from there. A few weeks ago, she developed a bad episode of gastritis, realized she had to stop. She's been trying to taper herself at home, but having a tough time of it. 2 days ago, she had a bizarre experience where she cut the amount of liquor in half, ended up seeing a dog curled up next to her bed in her apartment. This was kind of disturbing for her because she does not own a dog, and was even more disturbing when she heard from her partner that there was no dog there. She continued to see this dog waiting for her patiently in each room that she went into until eventually he disappeared. Any idea what's going on here?
Alcoholic hallucinosis.
Yes, nice. Spot on. It's a pretty bizarre phenomenon, but it's one of the sort of complications of alcohol withdrawal that can develop. Typically, people think this has to be something that develops after somebody's stopped altogether, but we actually see it more commonly when they're still drinking, but they've reduced significantly the amount that they're drinking. So it's quite striking to patients when they experience this. It can be a visual hallucination, like this dog. Sometimes there can be tactile hallucinations, right? That's the prototypical bugs crawling on the skin. People can have auditory hallucinations. The key thing here, though, is that there's no alteration of the mental status as well. So they're fully oriented during this, and otherwise appear sort of at their baseline mental status, but they're having this bizarre hallucination. They can be, relatively benign, like this dog in her apartment, or more disturbing, right, like crawling bugs on her skin. You guys have heard of people seeing pink elephants. That's another hallucination that can develop in alcoholic hallucinosis. If they're told that there is no hallucination, they'll believe you. But when they realize they're hallucinating, they'll be relatively disturbed by the fact. This is another thing that, like all withdrawal symptoms that can develop from alcohol withdrawal, responds well to benzos. In rare cases, you can actually use antipsychotics for this, but usually doesn't reach the point of being necessary because it's not causing that much distress that they would require an antipsychotic. Has anybody, heard of any cases of this or talked with any patients who've experienced this?
Yeah, I had a patient in the ED who came in alcohol withdrawal and said that there was a man next to him who was telling him to kill himself, which was really interesting because it got kind of dangerous.
Yeah,
But
yeah.
He got out of Vanclonopin and got better.
Really, yeah. So it can be, the mind can come up with many different forms of this, right, depending on the person. I had, a patient who was trying to detox himself at home, who looked outside his window, saw some people discussing across the street, then looked back at his bed and saw miniature versions of those people on his bed, continuing their discussion. Patient in the ICU, actually this is where I got the dog story from, but she hallucinated a friendly dog in the ICU with her, which sounds like not the worst hallucination to have. But they can present pretty bizarrely and be confusing for psychosis for some people. Okay, so she had an episode of alcoholic hallucinosis. She came in here, she sort of, I guess the last drink she had was about 6 hours before her seizure. Get a little bit more history. So she has a diagnosis of hypertension, episodes of pancreatitis in the past. She's never had a seizure before. Any thoughts on the hypertension diagnosis for her? I think it's something that we see, I don't know what you guys' experience with it is, but we see pretty commonly in people with alcohol use disorder, ongoing basis. And it's entirely possible that they don't actually have a primary hypertension, and this is just hypertension due to repeated episodes of withdrawal, right? They're not drinking when they go to their primary care doctor, for example. They may be a little bit hypertensive. So just, I thought sometimes we're managing withdrawal in the inpatient setting, giving them benzos, and they end up being more hypotensive on their antihypertensives, which you have to stop. So just an important thing to keep in mind. Family history, so substance use runs in the family for her. Father was a heavy drinker, died of cirrhosis. Both siblings use drugs pretty heavily. We know they're pretty strong genetic predispositions to substance use disorders. And it doesn't have to be, it's not like a genetic predisposition specifically for alcohol use running through the family. It's kind of a generic predisposition. So it could be alcohol, it could be weed, it could be heroin. But there's that genetic predisposition we want to think about as well. Social history, so she is dating somebody, but she lives alone, estranged from her family. And this is a common thing we've been seeing these days. She's been working in the food industry prior to COVID. Lost her job working in the food industry, and then her drinking sort of escalated from there. Denies any other substance use aside from smoking around a pack a day of cigarettes. On review of symptoms, aside from the recent seizure and some generic withdrawal symptoms, some GI upset, which is another thing we see commonly in alcohol withdrawal, as well as intoxication, right? And then numbness and tingling in her feet. Any thoughts on the numbness and tingling that she's reporting here?
Vitamin deficiency, B12.
Yeah, so commonly we think of that, right, in sort of peripheral paresthesias. Alcohol alone, actually, removing any kind of vitamin deficiency can be neurotoxic. So you can actually develop an alcohol-related neuropathy that will get better simply with cessation of the alcohol use. It also responds really well to gabapentin. So if you start somebody, on 300 TID of gabapentin, I've seen the neuropathies resolve over the course of the first 2 days on gabapentin. But it can be sort of a direct neurotoxic effect of the alcohol itself. So separate from the vitamin deficiencies we normally think of. Okay, so exam findings, right? These are just kind of some of the, the common symptoms you guys are probably familiar with for alcohol withdrawal. So she's tachycardic. She's not really hypertensive yet. Normal respiratory rate, she's breathing fine. When you see this kind of thing, I think the heart rate is one of the earliest objective findings that we have for alcohol withdrawal. So it's always a good one to keep an eye on. Typically, hypertension from withdrawal doesn't happen until much sort of later in the course. So tachycardia is one of the first things we'll sort of monitor when we're thinking about withdrawal and whether somebody's still in withdrawal. She's a little bit diaphoretic, right? We see that commonly. She's got the tongue fasciculations we see in withdrawal. Tachycardic again. Belly exam, she's got a slightly enlarged liver, right? She's been drinking enough to inflame her liver. Extremities are benign. She's got this fine tremor, right? We see with alcohol use disorder. And she's anxious and irritable. So these are all common things we'll see with alcohol withdrawal. What about lab findings? What do you guys think of, or what are some of the prototypical lab findings you think of with alcohol use?
An elevated mean corpuscular volume.
Nice. Yep. So the MCV can be elevated. And that's typically, right, if we're thinking about vitamin deficiencies causing MCV elevation, we think of it in combination with anemia. But people with alcohol use, it's from sort of the cytotoxic effects of alcohol itself. So it doesn't doesn't necessarily have to be associated with anemia. Anything else you guys see? What about those liver function tests, right? What are,
Usually it's in like ACT, it's like the double amount of the ALT. And then they
nice.
usually have like just like low total protein and also like low albumin as well.
Yeah, yeah. So somebody with really sort of chronic alcohol use disorder, just from the decreased nutritional state, oftentimes you can see that. Some of the other things that we think about here. So this person had actually a pancytopenia. So you can get pretty significant bone marrow suppression from heavy alcohol use. The first thing to go is usually the platelets. So oftentimes people see the thrombocytopenia. They think, oh, is this cirrhosis? Does this person have hypersplenium that's sort of eaten up all the platelets? But it can be purely related to the heavy alcohol use as well, and it'll, again, usually recover over time once they've stopped drinking. But you can see depression of all the three main cell lines with alcohol use. You got the elevated MCV, and you got the transaminitis. This patient, her bilirubins initially were within normal limits. If their bilirubin comes back high, what do you guys think about, or what's one of the concerns you might have? Any thoughts?
Alcohol-induced gallstones.
Gallstones, right? So yeah, there's always that, the risk they may have some other disorder causing these lab abnormalities. One of the
Hepatitis.
yeah, like an alcoholic hepatitis is kind of a big thing we worry about with elevated bilis. So people can cause enough inflammation in their liver that they do get that sort of backup of the bilirubin system, which can cause an elevated total bilirubinemia. Usually if that's the case, what we'll do is we'll trend the bili, and as long as it's not going up, we know we're safe. If somebody has an uptrending total bilirubinemia after they've been hospitalized, you want to think more closely about an alcoholic hepatitis. Some other labs just to sort of keep in mind, GGT is a great measurement that you can check for alcohol use. It's kind of like a hemoglobin A1C for alcohol use disorder. So typically increases around 3 to 4 weeks of heavy drinking, and will normalize again after 2 to 4 weeks of abstinence. So we'll see levels above 100 frequently in people who are drinking heavily. Another marker we use sometimes is CDT, or carbohydrate deficient transferrin. This is kind of similar. It increases after about 2 weeks of drinking and will normalize again after 2 to 3 weeks of abstinence. So sometimes we'll use that in the outpatient world to monitor abstinence in patients. Okay. Questions about the lab findings, exam findings, any of that stuff? Okay, so back to the course here. So she'd been to the floor, she gets some IV fluids, vitamins. She's placed on a CWAP protocol with Ativan PRNs. She gets just 2 milligrams of Ativan the next 6 hours, despite some ongoing tachycardia. And then she's another seizure on the floor at about 14 hours since her last drink. So what happened there? Why did she seize again? What do you guys think?
Ativan wore off.
The Ativan wore off. Yeah. Yeah. So, essentially, this woman didn't get enough benzos. And I think this is a problem we sometimes see with using the CWAP protocol on the floors. In theory, it's great and it works, right? But it does require that patients, are sick enough appearing or sort of pestering the nurses enough that they actually get assessed with the CWA and then treated if they do, score high enough on it. sometimes when people are, patients are more quiet, they're more introverted, they sort of fly more under the radar, they're going to miss doses using the CWAP protocol. And if they're underdosed, then they're at risk for progression of the withdrawal syndrome. So the takeaway here, right, is that in alcohol withdrawal, benzos are your friend. Don't be shy with them because they help. They're what the patient needs in that moment. I think typically when I think about this, right, because withdrawal can be so dangerous, right, people can, in theory, die from alcohol withdrawal. Typically, I think it's safer to err on the side of over-treatment than under-treatment, right? Because if you over-treat, what's going to happen? They're going to be a little over-benzoed, they may be a little tired, they may be a little sedated. Usually the doses we're using, we don't have to worry about respiratory suppression from benzos. Flip side, right, if you under-treat them, they may be at risk for seizures, for hallucinosis, for DTs. So I think when you kind of measure out the risk-benefit ratio for these meds, it's typically better to err on the side of treating a little bit stronger up front than trying to sort of avoid giving the benzos. So we talked a little bit about this earlier, but there's a question of which benzos to use. Typically, we think of the longer-acting ones as being a little bit better. So that's frequently Librium or Valium. They've got more active metabolites. They last longer. If we use shorter-acting ones, like you mentioned with the Ativan, right, the effects can kind of wear off over time. Whereas if somebody gets multiple doses of a longer-acting benzo, their serum level increases over time and sort of provides some safety. What I like to do when thinking about, the benzo protocol or the approach to take is thinking about sort of what level of risk they're at for alcohol withdrawal. And I kind of triage in my mind to lower risk versus high risk. So if they've had a few drinks a day, they get maybe mild tremors, but they don't really become ill when they stop drinking. Typically, you think of that as lower risk. High risk is really anybody with any kind of history of complicated withdrawal, said seizures, hallucinosis, or DTs in the past. Anybody who comes in with withdrawal symptoms and an elevated blood alcohol concentration, right? If they're already in withdrawal when they still have alcohol in their serum, that's a bad sign, right? Because it means they have a huge tolerance. People get tachycardic all the time, but if their pulse is spiking above 110, that may be a sign they're a little bit at a higher risk. Any kind of alteration in mental status, or if somebody's sort of older age, more frail, or if they just look clinically sick for other reasons. Those people I typically triage into the higher risk category in my mind. And then what that does for me is, I think about the benzo algorithm I'm going to use. If somebody's low risk, that's when I'll turn usually to the CWAP protocol with PRN Ativans, right? That's what we typically use here. I go there because, if like this patient in the case, right, if they miss a few doses or, they don't get fully treated, they'll probably be fine. They may be a little bit more anxious, they may be a little bit more tremulous, but they're not at risk for developing more serious withdrawal. For patients who are higher risk, typically we'll go with like a standing taper. So we'll get them, make sure they get some regular benzos in their system, keep the PRNs on as well. But this way, they're getting what they need, and that's going to prevent them from sort of developing further withdrawal symptoms. Then there's a loading dose algorithm we use less commonly, but I'll mention here as well just to touch base on it. So to start at the top, right, with the symptom triggered management, this is the CWAP protocol. And this is what I think, most patients get this when they first come in. So in its most ideal form, what this means is that a nurse comes in, checks a CWA on the patient every 4 hours, and gives them a PRN benzo whenever the CWA is above 8. And then if they require benzo, typically you want to recheck the CWA in an hour. Ideally, they're back below 8 and doing okay. If not, they get another benzo. So this does work for a lot of patients. I think the caveats with this approach are, kind of what we talked about before, right? So sometimes people will fly under the radar, miss benzo doses, and thus be at risk for progression of their withdrawal syndrome. The flip side, right? If you look at the actual criteria for CWA, there's a lot of this that is relatively subjective, and patients can report symptoms they may not actually be having if they're, trying to get more benzos, right? So there's no heart rate in here, for example, right? There are no vital signs. There are fewer of those objective findings that we think about when we're assessing withdrawal risk. So you run the risk of, under-treating certain people and some patients getting over-treated with benzos as well. When it comes to tapers, these are just, some sort of standard tapers that we'll set up for patients in the, the alcohol or detox unit. And this is what I typically use for anybody who I think feels like they're a little bit higher risk for withdrawal syndrome, right? Again, because it makes sure they get benzos without needing to sort of trigger a CWA. To set up a taper, essentially what you do is you choose your benzo, you choose a starting dose and frequency, and then you taper over a set number of days, either by reducing the dose of the benzo and keeping the frequency the same, or by keeping the dose the same and reducing the frequency. Right, so these are just some examples here. Happy to send these slides around afterwards if it'd be helpful. The Librium's up top because that's what we most commonly use, but there are some examples here for Valium or Ativan as well. Usually during a taper, we're going to keep the CWA available for any kind of breakthrough withdrawal symptoms they may be having. That way we know that, if we're kind of underdosing on the taper, they'll still get benzos if they need them. But, I think the 3-day one here is sort of a fine starting point for most patients. We'll get about 200 milligrams of Librium on the first day and then go down from there. And that's going to keep most patients, even higher risk patients, I think, safe for the, the course of their hospitalization. Do you guys have any questions about the tapers or how we set them up? Okay, kind of makes sense. I mentioned as well, there's this loading dose algorithm. So this is less common because it requires pretty frequent assessment. But essentially what we would do here is a patient comes in, we're worried about alcohol withdrawal. We'll keep an eye on them until their CWA is about 8 to 10. So kind of entering mild, moderate withdrawal territory. And then at that point, you give them doses of benzos every hour until either their withdrawal symptoms stop or they show signs of oversedation. Typically, we'll use Librium or Valium for this, longer-acting ones. And the idea is basically that, once their withdrawal symptoms stop after that hourly dosing, they've got enough, benzos for their body's needs. And because they're longer-acting benzos, they're going to sort of self-taper off over time. So we'll do this loading dose approach, and then people put somebody on the CWA for any kind of breakthrough symptoms that develop. But typically what we find is that we require less of the CWA benzos later on because they've been essentially loaded with benzos initially. Just a funny comic. Talking about benzos here. So back to our lady who had this second seizure on the floor. We realized, okay, so she doesn't get enough benzos. We've been under treating. What do we do? So we switch her to a Librium taper. We start her at that 50 milligrams Q6. Over the next day or so, she continues to have some tremors, intermittent tachycardia, and then at around 48 hours, the RN calls you. She reports noticing some confusion in the patient. You go over to assess her, find her in her room walking around. She calls you Mr. Librarian, asks where she can find a copy of Moby Dick, and you see her basically picking, imaginary books from imaginary bookshelves. At this point, she's disoriented to time and place. What's your differential at this point, or what do you guys think? Any ideas?
DTs.
DTs is it's obviously what I'm getting at here in this alcohol withdrawal talk. I think sometimes the complicating picture is the patient's now been getting benzos, so you wonder, are they over benzoed and sort of delirious from that? But this woman, in this case study is in DTs. And I think the difference that you can, and some of the symptoms you can look at to kind of distinguish from a simple delirium to DTs is the fact that she's been getting benzos, but she's still having some tremors. She's still tachycardic, right? We know the benzos activate the Gaba system in the brain, so they should be slowing everything down. So if she were just over benzoed, she wouldn't be shaking, she wouldn't be having elevated heart rate, right? And then the other key thing here is this sort of the quality of the delirium itself. So she's having vivid hallucinations and interacting with this hallucinated world, right? It's not alcoholic hallucinosis because she's disoriented. That's the primary difference there, right? In hallucinosis, we preserve orientation. Often people have insights into their hallucinations, but this disorientation is much more prototypical for what we see in the early stages of DTs. So DTs, I don't know if you guys know this beer. It's a little bit of a, it's not quite clinically appropriate because the pink elephants are actually associated with alcoholic hallucinosis, not DTs. Similarly, oftentimes people will, if you ask if they've had DTs, they'll say yes when they just get tremors, but it's not known as the shakes actually, right? This is a much more serious complication of alcohol withdrawal. Have you guys dealt with DTs? What do you know about DTs?
I think the last patient I had that had DTs was actually, it was pretty similar to the case that you just discussed. Is somebody coming in with alcohol withdrawal, you giving them benzos, they feel okay for a little bit, and then hours or the next day later, this person is like straight up delirium, hallucinating, trying to elope, and then we end up calling psych for recommendations of how much benzos we should give.
Right. Yeah. Yeah. So DTs is, when we talk about people dying from alcohol withdrawal, we're referring to DTs. That's sort of like end stage DTs. Nobody really dies from it anymore because we can treat it, right? And they often end up in the hospital. But this is sort of, in the bygone days, this was the cause of death. Do you guys know why that happens or why people die from it? I think it's sort of there are a number of factors, but what really happens is that people in DTs, once they get to this point of withdrawal, they can develop really severe autonomic instability. They can become really tachycardic, their pulse can drop, they can be hypertensive, hypotensive. They get these pretty rapid shifts in electrolytes, right? So they can become hyperkalemic really quickly. They can have hyponatremia as well that develops relatively fast in onset. So back in the bygone days, the causes of death were typically from arrhythmias related to these electrolyte shifts, or even possibly from strokes or heart attacks from really severe hypertension that results from it. So for DTs, typically most patients with once they develop this degree of alcohol withdrawal should be screened and usually accepted into the ICU. The reason for that is not necessarily these sort of, the blood pressure changes or the electrolyte shifts, because obviously we could theoretically manage this on the floor. The reason is that by the time they reach this point, they're going to require such massive doses of benzos that they will be at risk for respiratory suppression. So oftentimes in the ICU, I don't know if you guys rotate through, if you've seen this kind of thing, but they actually do get intubated prophylactically just because of the degree of sedation that they'll require to treat the withdrawal syndrome at that point. So there's this, the term refractory DTs here, which is what typically we see if somebody's reached the level of ICU care. And as you can see, right, these are large doses of benzos that they're requiring. And if they're still having symptoms with this dose of benzos, then basically they're at really high risk for the complications of DTs, and they typically require ICU management. Oftentimes intubation with, propofol, Precedex, other sedation agents that effectively treat the withdrawal syndrome. I think that one of the main things to know and think about with alcohol withdrawal is that the further along you get in the withdrawal syndrome, the harder it becomes to treat with benzos. So you really, once somebody's at the point of having seizures, if they're having hallucinosis, you're already behind the game. And that's why it's really important to, again, err on the side of overtreatment initially when people come in, because if we get on top of it quickly and sort of early on in the course, it doesn't progress the same way. It's much more easy to manage. But once they reach the point of having a seizure, or God forbid, entering DTs, the doses of benzos that are required just escalate and escalate, and it can be really pretty excessive. You guys have questions on that front? I don't know if you've sort of run into this in the in the critical care units at all.
Yeah. Hi, Dr. Suter. I have one question.
Yeah.
So we had this patient in the ICU. So he was in DTs and he was kept on the drip, Ativan drip, for quite a while. And we eventually started him on propofol as well. So he was still like agitated and very, very tachycardic and hypertensive. So like my question is, how can we consider starting him on or giving him just one dose of Haldol in between ever?
Yeah, for sure. If it gets to the point where you're sort of managing the more severe complications, it's fine to use Haldol for agitation if they're becoming really agitated and the other sedation agents aren't working.
Okay, so we can give Haldol in alcohol withdrawal as well. Okay.
Yeah. And if somebody's having bad hallucinations or something from the withdrawal, it's okay to use Haldol, and it will be effective. It'll help. I think ultimately, upping whatever sedation they're on will also help and may more effectively sort of address the underlying, what's going on in the brain. But it's definitely fine to use Haldol in those cases if it helps to sort of calm the patient down and lower the risk. I think what you see oftentimes when patients reach this course is it takes a while for them to get better. So it takes large amount of benzos or other forms of sedation over a long time. I don't know how you guys manage that patient, but typically the way it's done, right, is they reach the ICU, they're intubated, they get placed on heavy amounts of sedation. And essentially what you do is you sort of attempt to wean the sedation off over time and see if their vital signs tolerate it. So you kind of follow the vital signs and the degree of agitation. And if they're still elevated, they still are in a withdrawal syndrome, they're still in DTs, and they need ongoing treatment. Yeah, other questions about DTs or how to approach it or how to think about it?
I have a question. Oh, please go ahead.
Oh, Diane, go ahead. And after that, there's a question from Abhinav on the chat, Dr. Suter.
Yeah, I just had a question of for patients with refractory DTs, what's kind of the most amount of benzos that you've seen a patient require?
To be honest, once it hits the point of refractory DTs and they're in like the ICU, say, I, as a psychiatrist, I'm not seeing them. They're usually in better hands than myself. So I don't know. A lot of the literature points to 400 plus milligrams of diazepam in a day, which is a huge amount. But oftentimes at that point they're on propofol as well, which is helping to treat the withdrawal syndrome too. Or they're on Presidex, phenobarb. These all sort of act on the Gaba system as well, so they're supplementing the benzos. Was there another question, or there was one in the chat maybe?
Abhinav is asking, does Presidex or Haldol end up masking the need for benzos or increase the risk for DTs?
Yeah, it's a good question. I think, once they're sort of in the DT state, they're going to be on enough sort of standing benzo to treat, or the Presidex as well, like I mentioned, the Presidex actually works on the GABA receptors to some degree, so it's helping to treat the underlying cause as well. So usually they're not getting enough Haldol per se to cause a masking effect. In theory, it is a possibility, but the Haldol is usually going to be a dose every now and then, but won't be enough to sort of sedate them with the degree of withdrawal and agitation that they're in. Okay, so we're just getting to the end here. I have 2 more slides I just wanted to share. There's one thing that we forgot sort of early on in the course here. I don't know if you guys notice it or can pick it out.
MI.
MI, absolutely. Says the psychiatrist in the room. Yeah, so motivational interviewing, but also the cigarettes. So just a reminder to keep on talk, to ask people about cigarette use and treat it if it's there. Nicotine withdrawal is actually a really common cause of AMAs from the hospital. People develop really strong cravings and they leave before completing their treatment and can put themselves at risk. So it's a preventable cause of AMAs that I think we should all just kind of keep in the back of our minds. Obviously, it can lead to other disruptions, right? People can become more agitated or irritable from the withdrawal. The patch works wonders. Probably better than the gum because, again, it's kind of like the standing taper. We know that they've received the nicotine that they need.
I have a question. I feel like a lot of patients that I see, at least in the CPEP, are like, oh, I e-cigarettes like all the time. And they just have like no ability to quantify anymore because there's no packs. And I'm wondering how you titrate for those patients.
Yeah, no, totally. So, most literature says that like a cartridge, one of the cartridges that you put in the e-cigarette, it's approximately equivalent to a pack of cigarettes a day in terms of the amount of nicotine. So usually I'll ask people about how many cartridges they use in a day, or how long it takes them to finish a cartridge. And then that'll kind of clue you in a little bit to what their nicotine needs may be. Okay, I'll leave you just with this picture here. This is kind of just the overall time course for alcohol withdrawal. So as you can see, the seizures can happen really early in the withdrawal course. So we saw in this case, they're sort of one of the first symptoms that she developed. And then DTs usually is later on in the course. Typically by 5 days out from the last drink, you're safe and sort of clear from any significant withdrawal risk or complications. So it's always good to know when their last drink was because that kind of clues you into how worried you need to be about withdrawal symptoms. Okay, are there any questions? Okay. I hope that was helpful for you guys. Oh, I wanted to leave you too with, this is our consult service. You can also feel free to reach out to me by like Epic Chat or whatever other means if you have curbside questions for patients. We're all based primarily at Mount Sinai West. We do go up to Mount Sinai Morningside as well, but it sometimes takes us a little bit longer time to get up there. It's just sort of the unfortunate thing of having the addiction services primarily based in West. To reach us, you just call the PsychCL line. Leave a message with them. That may change in the future, in which case we'll let you guys know. But we're available for questions, and I'm always happy to help with these cases. I know there's plenty of it in hospitals.
Thank you so much, Dr. Suter. We'll definitely keep that in mind. And then if I think you mentioned you wanted to share some of the slides with us so that we have
Yeah,
sort of a